This video demonstrates the technique of laparoscopic Nissens fundoplication. The child had previously been operated for congenital esophageal stenosis and was having reflux, which was causing nutritional deficiency despite all efforts. There was vomiting and failure to thrive, and contrast esophagogram showed gastroesophageal reflux. We used 5 ports, 2 under the xiphisternum as operating ports. The telescope was put in above the umbilicus and a liver retractor was put in through the right lumbar region. The port positions are shown in the diagram. And this is the liver retractor port coming in. A 5 mm fan retractor was used for retracting the liver, and a grasper inserted through the left lumbar region was used to put traction on the gastroesophageal junction to make it easily visualized. At this point we can see that the stomach is somewhat distended and this was emptied out through a nasogastric tube. There we can see the port for putting in the gastroesophageal junction grasper in the left lumbar region. And this was used to apply traction on the gastroesophageal junction. That is the trocar for the first operating port coming in under the xiphisternum and the second operating port. After applying traction downward on the gastroesophageal junction, the first step was to divide the left triangular ligament so as to mobilize the left lobe of the liver somewhat. As this was one of our earlier patients, we have undertaken this maneuver, but with increasing experience, division of the left triangular ligament is really not necessary for accomplishing a comfortable fundoplication, as the gastroesophageal junction and the lower esophagus can be mobilized without dividing this ligament. The next important step is opening of the phrenoesophageal membrane, as this is the ligament which hides the diaphragmatic crus and the position of the esophagus. An important guide to the phrenoesophageal membrane is the omentum which is overlying the caudate lobe of liver, and this is being divided here with the caudate lobe in the background. The caudate lobe is an important landmark for the right crus of the diaphragm, which usually lies under its cover. Just under the caudate lobe we have the inferior vena cava, which should always be avoided during this dissection. As the Maryland opens, we can see part of the right and anterior surface of the esophagus as it goes into the esophageal hiatus, and in a little while, when the caudate lobe is depressed, we will be able to clearly see the right crus of the diaphragm. Now, just behind this peritoneum overlying the abdominal part of the esophagus, we can see the muscular fibers of the right crus of diaphragm in that little pool of blood. We are now clearing away the peritoneum from the anterior surface of the esophagus in order to outline the diaphragmatic hiatus clearly and then begin the dissection behind the esophagus. So once the front part of the phrenoesophageal membrane is divided, we can see that the upper margin and the right crus of the diaphragmatic hiatus comes into view, and we can see the U-shaped arch as it encircles the esophagus, which is entering the inferior mediastinum. It is necessary to dissect the esophageal circumference all around, both on the right and left sides and the anterior and posterior sides, so as to create a clear window through which the fundus of the stomach is going to be drawn. The muscle fibers of the right crus of diaphragm are clearly visible now, and we are clearing away the adhesions on the left side of the esophagus towards the spleen to delineate the left crus of the diaphragm. Here we can see that both the crura of the diaphragm are now outlined, and we are now creating a plane between the right crus and the posterior surface of the esophagus. There is a bit of periesophagitis due to previous esophageal surgery, and we just have to gently dissect away between the crus of the diaphragm and the esophageal muscle in order to completely mobilize the circumference. It is relatively easy to see into the inferior mediastinum at this stage, and that is where the dissection should begin as we try to get round the back of the esophagus. It is also important to mobilize the esophagus in the mediastinum for a distance of at least 6 to 7 centimeters so that a good length of intra-abdominal esophagus can be created for doing the fundoplication. Without this, there are high chances of recurrence of the reflux and sliding of the fundoplication into the mediastinum. We can see that we have got round the back of the esophagus on the right side. There are just some filmy adhesions holding it up, and there's the grasper appearing on the left side, which means that we are completely through on the back of the esophagus. Now, keeping the grasper in position, we have drawn in a length of infant feeding tube behind the esophagus, and this will be used as a sling to hold up the esophagus so that the posterior dissection becomes a lot easier. The sling is now held in the grasper, and this will be used to exert traction on the esophagus and the gastroesophageal junction in various directions to facilitate subsequent dissection. And there we can see that with this simple maneuver, a clear window has now become visible behind the esophagus, which can be enlarged enough to transmit the fundus of the stomach. Somehow dissection in this area generates a quantity of blood-stained fluid which can be suctioned away as convenient. So that's the gradual enlargement of the window behind the esophagus by progressive division of the filmy adhesions. And we'll now proceed to mobilize the fundus by controlling the short gastric vessels to free up a sufficient length to come behind the esophagus. Control of the short gastrics is best done at the lowermost point. There we can see the first of the short gastrics entering the fundus of stomach, and this will be controlled by the harmonic scalpel. So we have isolated and divided the first bunch of short gastrics, and that will free up the fundus to a certain extent. And we just need to see whether we need to divide any more of these vessels to give a sufficient length of fundus to come behind the esophagus. I think that next bunch with the transparent mesenteric window behind it can be divided, and that should be enough to get the fundus behind the esophagus without tension. Here we are creating a window in this to coagulate the short gastrics. However, as we can see the transparent greater omentum, we can simply divide across it with the harmonic or with a right angled hook to free up the gastric fundus. Of course, care has to be taken that these vessels are properly controlled, because they can retract into the greater omentum on either side and lead to troublesome bleeding if not secured properly. As we invariably use an energy source to divide the short gastric vessels, it is important to note that on the gastric side, the Maryland grasper is holding the vessels a little away from the gastric wall, and they are then being divided by the harmonic scalpel. Even when using a cautery hook, This principle should be followed so that there isn't any injury to the gastric fundus at all. Once a sufficient length of gastric fundus has been separated, the sling is removed and we make a trial to see if the fundus will come behind the esophagus without tension. The next important step is suturing of the diaphragmatic crust to narrow down the diaphragmatic hiatus and also create a length of intra-abdominal esophagus. We are using 2,0 silk on needle here as Ethibond is unfortunately not available in our institution. That is the bite being taken through the left crus, and in the same swing we are also including the right crus of the diaphragm. You notice that the needle goes in a little beyond the peritoneal covering of the right crus so that the fibers don't tear when the knot is tightened. The needle is withdrawn and the end of the suture drawn into the abdomen for the intracorporeal knot. So that is the first knot being completed and tightened and resulting in a degree of narrowing of the diaphragmatic hiatus. Clearly, however, one more suture will be needed to snug it down around the esophagus. There are some reports of keeping a bougie or a thick Riles tube in the esophagus to prevent over tightening of the diaphragmatic hiatus. However, in practice it is seen that a visual assessment is more than adequate and one can generally make out that the hiatus is loose around the esophagus. So that is the second stitch going in. The right crus has been taken up first here, followed by the left crus on the other side. As you can see, it is a somewhat limited working space. However, moving slowly and keeping things under vision helps to prevent mishaps. So that is the second knot tightened, and the diaphragmatic hiatus is now sufficiently narrowed to prevent the riding up of the Nissens fundoplication, and we can proceed with the fundal wrap. So as we can see, we have a large floppy fundus which we are now bringing round the esophagus by holding it in a grasper which goes behind that organ. It is very important to ensure that there is no twisting of the fundus, and that can clearly be seen here that the medial margin is being drawn under the esophagus. And it comes through nicely and loosely and lies there freely without trying to retract backwards. And we can also see that as the fundus is flattened out, there is no twisting. We have here readjusted the feeding tube sling a little bit, and we can easily see that the two parts of the fundus which are going to be sewn together are lying loosely and comfortably on either side of the esophagus, and here they come together quite nicely, leaving a more than a finger's width going under the fundal wrap. So the uppermost part of the edge of the gastric fundus is going to be sewn to its counterpart on the left side of the esophagus, and then we'll proceed downwards from there. So that is the first stitch in the fundus, and we can see that there is a very loose wrap here, and we'll wait to see how many stitches are needed before we snug that down. We're just removing the needle here before tying the second knot in order to make it easier for the thread to go around the Maryland forceps, and that is the knot secured. So there we see the silk suture actually fraying because of a very pinpointed grip by the Maryland's forceps. The way to avoid it is to get a good grip on the suture, and with the knot secured, the ends are divided. So here we are ready to take the second stitch of the fundoplication. That is the near side of the wrap, and we are also taking the wall of the esophagus or the gastroesophageal junction, and conveniently the other side also. So since the needle is long enough and it is a 3 by 8 circle instead of the standard 5 by 8, we can take all the three parts together. However, this is really dependent on the convenience, and if it is more convenient to take the sides separately, then that is what should be done. It's all a matter of how comfortable the surgeon is rather than any fixed set of rules. So there we've seen the second knot being snugged down, and it's still a loose wrap. There isn't any tightness in it, and there's plenty of space under the wrap and on the surface of the esophagus. Okay, so that fundoplication looks all right, and I don't think there's any need to put any further sutures because the lower end of the esophagus is well encircled by the gastric fundus. I know that there are mentions of securing the wrap to the crus of the diaphragm to prevent it sliding up into the mediastinum, but as we have snugged the diaphragmatic hiatus around the esophagus, I don't think this wrap has any danger of sliding up into the chest. And therefore, with the closure of the ports, we come to the end of the operation. The child was kept on nasogastric drainage for a period of 48 hours after surgery, after which oral feeds were gradually started. The child was discharged home on the 7th postoperative day. At first follow-up 3 months later, he had reported 2 episodes of gas bloating, which relieved spontaneously. He has been seen in OPD at the duration of 18 months after the operation and was gaining weight well. Thank you.